let's say you have a case of a woman, a young woman in her mid-20s, who comes into the office with urinary frequency, urgency, and burning, as well as suprapubic tenderness. You go ahead and you get her vital signs. She doesn't have a fever. Her blood pressure is fine. Her pulse is fine. And she's not complaining of any flank pain. In terms of sexual history, she has one partner she's monogamous with. She does not use contraception, and her last menstrual period was 24 days ago. So, taking all these things into consideration, what's the first thing you want to do? I mean, on your differential, UTI is obviously there. You also have to think about pyelonephritis or some type of sexually transmitted disease, that may cause cervicitis, urethritis, or PID, right? But highest on this thing is going to be UTI. In addition to that, the fact that she has sex and she doesn't use contraception, last menstrual period was 24 days ago, you have to do a pregnancy test on her. Even if her menstrual period is not 24 days ago, still do a pregnancy test on her, okay? And we get all these things. Now, do a physical exam. I mean, the more important things about this physical exam are going to be the abdominal exam and the genital exam. You want to see if there is any purulent discharge coming from the cervicitis, see if there's any tenderness to the uterus on bimanual examination. And let's say all those things check out negative. So we think that any kind of STI is much lower on the differential. Cool. We see that there is no fever, there's no flank pain when you go ahead and you hit the kidneys with the costovertebral angle, and so we say pyelonephritis is also less likely because of that. Fine. What are you going to order? Urinalysis, first thing you order, right? We want to see if there's nitrites, leukocyte esterase, or bacteria, whatever it may be. Also, the pregnancy test, which I mentioned already, and then based on those two things is what we're going to base our treatment on. Let's say you get the UA and it comes back positive for nitrites and leukocyte esterase. Okay, this tells us, yes, it's acute cystitis. Next thing, you get the pregnancy test back. That's also positive. Oh shit. Okay, what are we going to do now? Fine. If she were not pregnant and she just had the cystitis, how would we treat her? We would give her a 3-day course of Bactrim, which is trimethoprim and sulfamethoxazole. If the person has a history of allergic reaction to Bactrim, then another option you can use is a fluoroquinolone such as ciprofloxacin. Now, in this case, she's pregnant, so we can't use those two medications. Bactrim is a folic acid antagonist. You have a baby growing. You don't want to give a folic acid antagonist when a baby's growing. You don't want to give ciprofloxacin or fluoroquinolone because it can cause damage to the cartilage and bone for the developing baby. So we have other options for cystitis in pregnancy, specifically cefpodoxime, all right, which is ceftriaxone, or amoxicillin clavulanate, which is Augmentin. Those are two options you have, cefpodoxime or amoxicillin clavulanate, and it's a 7-day course for each one of those, okay? Another option that you can consider is fosfomycin, a single dose of fosfomycin, or nitrofurantoin, which you can give in the second or third trimester, not in the first. This person just became pregnant, okay? Their last menstrual period was 24 days ago. They're in the first trimester, so we can give them the cefpodoxime and the amoxicillin clavulanate for a 7-day course, send her home. After that, there's one final order that you want to do before you wrap up the whole entire case. And the final order that you want to do is a urine culture 1 to 2 weeks after the treatment has been accomplished. So after that 7-day course of Augmentin or cefpodoxime, whichever one you chose, a week or two after that treatment is over, you do a urine culture test to make sure that the bacteria has been eradicated from the urine. If you get a patient who is abusing substances, you have to take the opportunity to talk to them about how to change their behavior and stop using substances. And so the psychotherapeutic technique that is most often used is motivational interviewing. So you have to understand what motivational interviewing is. This is basically evaluating at what stage the person is at, and then modifying your approach based on that stage that they're in. Okay, so let's go to the different stages. They're going to be pre-contemplation, contemplation, preparation, action, maintenance, and identification. And so let's talk about the first one, pre-contemplation. The person's not ready to change. They don't acknowledge that what they're doing is bad to them. Okay, so if you assess that somebody's in a pre-contemplation stage, they just don't give a fuck about what's happening. What you need to do is encourage them to evaluate what's happening right now. Okay, you can kind of personalize the whole thing for them. If you see that there's something that is important to them that they may care about, you can kind of like slip it in there. But don't try to talk to them about quitting the substance. Okay, they don't want to hear it. Okay, and don't try to threaten them with some kind of repercussion that may occur. Okay, so like an example of that is like, don't tell them, hey, like, you could possibly, lose your job or something like that, or get arrested, whatever it may be, doing this. No, this stage is you can't threaten them with any consequences. But what you could do is ask something like, hey, so what do you think you'll lose or gain if you give up drugs and alcohol? You see, it's a very open-ended question. It has no particular statement or consequence to it. Next thing, let's talk about the contemplative stage. They're thinking about changing. They start to acknowledge the fact that there's negative consequences to their behavior, but they're kind of ambivalent about it. They're like, all right, whatever. If it happens, it happens. If it doesn't, it doesn't. Right? In this case, you try to encourage them to evaluate the pros and cons of behavior change, and you try to promote new positive behaviors. Let's talk about the next stage, preparation. They're ready to change. They have made the decision that they are going to change their behavior. This is a decisive step. Here, you encourage them to take small steps, small initial steps. And if there's anything positive, right, that's occurring to them, you reinforce that. You point that out to them, like, hey, look, ever since you made the decision to do this, what do you think are going to be the positive outcomes of this behavior change? And they'll tell you it's going to be this, that, and a third. You say, hell yeah, that's exactly what's going to happen. So keep that in your mind. Next thing is action. They actually did something. Okay, they actually did something. There's actually change in their behavior. Okay, they may have quit for a week or a couple of days and then relapse. It's okay. If they relapse, it doesn't matter. The fact is that they took action on it. Okay, and so what you do in this stage is that you identify ways in which they can continue making those changes, and you start to enlist social support. So whether it's like an AA group or going to therapy, whatever it may be, and you help them promote their sense of self in dealing with obstacles that may come to try to take them off the path. Next thing is maintenance. At this point, the changes have been integrated into their life. Okay, so it's not that they've just taken the first step and maybe quit using for a couple of days or weeks or whatever it may be. They have done this multiple times already. There's a change in the way that they're viewing their life, and they're focusing more on not just stopping the substance abuse, but they're focusing more on preventing relapse. Okay, so in this instance, what you want to do is you want to give them follow-up support. You want to reinforce the intrinsic rewards that they have from not using the substances. And you want to develop strategies with them to prevent relapse. Okay, whether it be, people, places, and things, right? Staying away from people, places, and things that can trigger that craving for them. Okay. Last is identification. So at this point, the behavior for them is automatic. All right. And this has the new person that they have become is who they are. They have a completely new identity at this point. Okay. And I mean, all you do at this point is give them a high five. All right. Tell them good job for doing what you did and what you continue to do. Let's say you have somebody who had their thyroid gland removed. Um, there's something that you need to be concerned about here, which is accidental removal of the parathyroid gland. And so we need to look at what are the symptoms that may arise from that. So once you get to a level of serum calcium that is still, it could be lower than normal, but it's still above 7.5, the symptoms will be non-specific. So it's going to be muscle cramps, depression, and fatigue. Okay. However, once you start getting to the point where you start dipping below the 7.5 and specifically 7, once you get below 7, you start to have neuromuscular symptoms. So this is going to be tetany. You can also have a QT, interval prolongation, and even seizure. Things that you can look at to test this out and see if the person is at this level before drawing blood calcium, obviously, is a classic Trousseau sign, which is carpal spasm induced by inflating a blood pressure cuff on the upper arm for 3 minutes. Okay, and you'll see their carpal spasm in their hands. Another thing is Schwostek sign, which if you tap over the facial nerve anterior to the ear, you will get facial muscle twitching. Okay, so these are ways that you can induce that neuromuscular findings of hypocalcemia. Other things that may cause hypoparathyroidism are genetic disorders such as DeGeorge syndrome, radiation to the area, or autoimmune diseases. You can also have perioral numbness or numbness and tingling in the extremities as well. This is another finding. Diagnostic findings that you'll find: hypocalcemia, hyperphosphatemia, 24-hour urinary calcium excretion will be elevated, so they're just dumping calcium out the pee, and obviously a low parathyroid hormone level. Okay. Management: calcium supplementation. If it's really, really bad, if you're below 7.5, you can do intravenous calcium gluconate, and you also do vitamin D supplementation as well. Cell-free fetal DNA testing is something used to screen for trisomies 13, 18, 21, and other sex chromosome aneuploidies. It's very easy to do. It's non-invasive. So because of that, this is something that is now used as a routine screening method for any woman who is pregnant over the age of 35. So remember that greater than age 35 is now considered as advanced maternal age, where the risk for trisomies or other sex chromosome aneuploidies is increased. Besides a advanced maternal age, there are other indications that will tell you to use cell-free fetal DNA testing, and these are sonographic findings associated with fetal aneuploidy, a prior pregnancy with fetal aneuploidy, or parental balanced Robertsonian translocation. What are some of these sonographic findings associated with fetal aneuploidy? So thickened nuchal fold, which is it's something you can find in pretty much any trimester. Cystic hygroma, hypoplastic nasal bones, fetal edema, growth restriction, short and long bones, ventriculomegaly, pyelectasis, which is dilation of the fetal kidney, or overall just urinary tract dilation, echogenic bowel, choroid plexus cysts, echogenic intracardiac focus, structural anomalies such as esophageal atresia and hydrops fetalis. Do these findings mean that the fetus definitely has a chromosomal abnormality? Not necessarily, but it does raise high suspicion for it. To recognize measles, you have to be aware of the age range that this affects. So it's usually going to be children below the age of 5, and could be a child less than 2 years old. Okay, but most of the people that it affects are under the age of 5. So this separates school-age children from non-school-age children. Okay, so measles is going to be for non-school-age children. And how does it start? I mean, the prodrome is kind of non-specific. It's cough, coryza, but then you have conjunctivitis and Koplik spots. Okay, so erythematous conjunctivitis and Koplik spots are much more specific. Okay, and another specific thing is going to be the maculopapular exanthem, the rash, which starts off cephalocaudal and then can become centrifugal, spares of palms and soles. So you may have, for example, a child that comes in with a rash on their cheeks, okay, and that's the only rash that you see before it spreads to the trunk, okay, and you may just see this rash on the face and think, oh, maybe it's slap cheek parvovirus. So parvovirus more commonly affects school-age children, okay, so that right there cuts that out. Another thing that you will very commonly find in the history is either no vaccinations or incomplete vaccinations, okay, not getting the full dose of the MMR vaccine. That's another thing that you will almost certainly find in the history. And the treatment for measles, intravenous fluids, antipyretics for the fever, and in some situations we also give vitamin A to reduce the risk of complications. Okay, and what are these complications that can occur? Pneumonia is one of them, and then there's neurologic ones. So 3 different time frames of encephalitis. First one, it will be encephalitis that develops days after the beginning of symptom onset. Another one can be weeks later, which is acute disseminated encephalomyelitis. Another one can be years later, which is subacute sclerosing panencephalitis.